In these lecture series on hematology part of internal medicine, we have been discussing various anomalies starting from anemia, and then we moved on to certain other abnormalities. Now, continuing our discussion, we are going to talk about the myeloproliferative disorders today. The myeloproliferative disorders, as the name signifies, are the proliferation of the myeloid lineage of the hematopoietic stem cells. Now, there are a lot of myeloproliferative disorders, and we are going to talk about them in detail in the coming lectures. Our basic topic of discussion today is the polycythemia vera, which is one of the myeloproliferative disorders. The other important myeloproliferative disorders which we are going to talk about in the coming lectures are the myelofibrosis, essential thrombocythemia or essential thrombocytosis, and CML or chronic myeloid leukemia. Now, polycythemia, as the name signifies, poly means many. So this means there is an increase in the number of cells, and emia means blood, as I told you in the previous lectures. So as the name signifies, polycythemia generally means that an increase in the number of cells in the bloodstream. Now, as I told you that it is a part of myeloproliferative disorders. As we know that the hematopoietic stem cells have two major lineages, the lymphoid lineage or the myeloid lineage. The lymphoid lineage is primarily concerned with the B and T lymphoid cells, whereas the myeloid lineage, it moves on and gives rise to all the erythrocytes, which later on transform on into the RBCs, the platelets or the thrombocytes, and the various types of WBCs, which, for example, the neutrophils and so on and so forth. Various types of myeloproliferative disorders target various cells population. For example, in essential thrombocytosis or essential thrombocythemia, as we are going to talk about in the coming lectures, platelets are the number of cells that are generally enlarged, while the other cell count is generally normal. Similarly, in chronic myelogenous leukemia or CML, white blood cell count is the one which is targeted. In polycythemia vera, RBCs or erythrocytes are the cell population which is majorly being affected. But along with it, because it is a stem cell disorder, it has some effect on the other cell lineages, primarily the platelets and the white blood cell count. So along with the erythrocytes, we have an increase in the number of white blood cells and an increase in the number of platelets. These cells are perfectly normal functioning, but they have an increase in the bloodstream, which leads to an increased viscosity in the blood and an basically abnormal ratio of the blood cell to the plasma count. And as we are going to see in the coming clinical features in the pathophysiology, what happens because of this imbalance. Now, having this background knowledge, let's look at the pathophysiology of polycythemia vera in slight more detail. As we know that a common hematopoietic stem cell, it is destined to either go into the myeloid lineage or a lymphoid lineage. Now, in this lecture, we are primarily concerned about the myeloid lineage of the cells. So a common hematopoietic stem cell, what happens is that there is a mutation of certain receptors. Before going into the detail, let's have a background of what happens. There are certain types of receptors in the cell membrane of the various cells, especially these cells which are targeted to become either the erythrocytes or the platelets. We are going to primarily talk about the erythrocytes. Now, when certain types of ligands like erythropoietin, thrombopoietin, or interleukin, or the various types of factors stimulate these receptors, which are the membrane-bound tyrosine kinase receptor, they get phosphorylated. After phosphorylation, basically they get activated, and downstream they activate a series of response, which is carried out by the different type of tyrosine kinase called a JAK or a JAK2 specifically for erythrocytes. JAK2, when it is activated, it gets phosphorylated and then it activates STAT, which is another cell types of tyrosine kinase in the cells. That JAK-STAT activation moves the STAT molecule to the nucleus of the cell. And when the STAT molecule is inside the nucleus, it leads to the proliferation of the cell. This is a normal response which happens to the binding of any ligand on the receptor tyrosine kinase, specifically in the erythrocytes. What happens in polycythemia vera is that the JAK receptors, they get mutated, and with the help of this mutation, specifically almost 99% of these cells which undergo these mutation have the JAK2 V617 to F mutation, which is basically the JAK2 receptor at the position 617 replaces the V for valine with phenylalanine, which stands for F here. So at the 617 place on the chromosome 9, in which the JAK2 gene is located, there is a valine to phenylalanine mutation. What does this mutation do? This mutation makes the cell autonomous. You can say that the cell starts dividing without any outside signals. So there is a clonal proliferation of the cells. This mutation majorly targets the erythrocyte. So erythrocyte population is the one which we are going to see affected the most and leading to all the signs and symptoms in these patients. But along with it, since they have a common hematopoietic stem cell precursor, a few of the platelets, for example, the thrombocytes and the various types of white blood cells, they can also get affected, leading to an increase in their cell population as well. So the important thing here to remember is that erythrocytes are the major cells which are being affected by this mutation, and along with it, there is a slight increase in the platelet count and the WBC count as well, as we are going to see in these progenitor cells. The granulocyte monocyte progenitors are the ones which lead to the formation of white blood cells or WBCs. The erythroid progenitors, which are the major cells being affected, they lead to the RBCs production. And the megakaryocyte progenitors lead to the megakaryocyte formation, which eventually leads to the platelet formation. So as a result of this, the condition which we develop is called Polycythemia Vera. It has classical signs and symptoms which makes it easy to distinguish from the other myeloproliferative disorders. The other myeloproliferative disorders, they target one cell population. For example, essential thrombocytosis. As the name signifies thrombocytosis, it classically targets the megakaryocyte progenitor cells or the platelet population. The RBC count and the WBC count is normal to slightly elevated. And the CML, or the chronic myelogenous leukemia, which is a leukemic condition, it targets the WBC count. The RBC count and the platelet count is not affected. Based on this pathophysiological knowledge and the background, let's look at the clinical features. Now, what happens when the RBC count increases? Now, the RBC count is basically defined by the RBC mass divided by the plasma volume. In polycythemia vera, as compared to the other types of polycythemias, which we are going to talk about, the RBC mass increases exponentially. And there is also a slight increase in the plasma volume. So the cells, for example, if a person has 14 grams per deciliter of hemoglobin, so that means that that person in the bloodstream has 50% of the RBC mass and 50% of the plasma volume. When this balance is disrupted by an increase in the RBC mass to, let's say, 70%, the blood becomes more viscous. There is not, the fluidity is lost, and the cells, the blood has difficulty passing through the small areas. That leads to all the clinical signs and symptoms. Starting off, we're going to see thrombocytosis. As I told you, that the platelet count will be increased because this mutation also affects the megakaryocytic progenitor cells. There will be an increase in the leukocyte count. This is not a very marked increase, but this is slight. There are more increase as compared to a normal population. As you saw in the case study where Mr. Smith has a leukocyte count of greater than 13,000 and the thrombocyte count of greater than 5,000 per microliters. The spleen will be enlarged. There is splenomegaly because to keep up this rapid turnover of cells, we have a process called the extramedullary hematopoiesis, because the bone marrow cannot keep up with all this pace of the cell requirement. So the blood cell formation is also shifted outside the bone marrow, specifically in the extramedullary organs like the spleen, your liver, and your lymph nodes, etc. So the spleen will be enlarged because of this, and that leads to a plethora of symptoms on its own. There is a classical condition called aquagenic pruritus, and this condition is specific to polycythemia vera, and it helps us to distinguish polycythemia vera from other similar abnormalities. What happens in aquagenic pruritus is aqua means water. So this is related to water, and pruritus means itching. So in aquagenic pruritus, because the white blood cell lineage also involves the basophils, the basophils release histamine. Especially, for example, the patient will classically complain that after I take a hot shower, my body starts itching. And this is a classical sign and symptom of polycythemia vera. And this is because when the patient takes a hot shower and there is an increase in the body temperature, that leads to release of the histamine from the basophils. And that leads to an overall itching process in the patient. So this classical symptom is specific to this polycythemia vera. It is not found in other types of polycythemias. Hyperviscosity because of an increase in the number of cells, the platelets, the WBCs, all the cell lineages are increased. This leads to an imbalance in the normal cell and the plasma volume proportions. Moving on, when this hyperviscosity, when the blood is hyperviscous, it basically leads to obstruction in the blood flow in the various organs. When it happens in the CNS, all the signs and symptoms of CNS will be evident. Certainly, the patient will experience vertigo, tinnitus if the bloodstream of the inner ear is affected, headache. Patient might have visual disturbances if the eye blood stream is affected. There might be certain transient ischemic attacks or TIAs, which can basically simulate like the patient is having some stroke, but these are basically self-sustaining and they improve in 24 hours. But all of these signs and symptoms are basically because of the hyperviscosity of the blood. The blood is not easily able to move through the small capillaries, which it was able to do before these patients developed these symptoms. The symptoms of polycythemia vera basically develop over a period of number of years. It is not that the patient today wakes up and he starts having all of these symptoms. This disease has a long period. It might start in someone in their 20s. In some patient, it might start in their adult age, for example, 50s and 60s. So there is no certain age of the onset, and the symptoms take basically 5 to 10 or maybe longer years to evaluate over a period of time. So it's a slow evolving disease, and at one time the patient might have only one symptom. Not all symptoms will be evident in the patient at one time, but the patient's disease might progress. If the disease onset is in the later part of the age, then the disease prognosis is definitely poor as compared to an early onset of the disease. Moving on with the clinical features, the patient will have a systolic hypertension because of the increased viscosity. The arteriolar pressure will be increased generally throughout the body. Thrombosis. It is one of the major manifestations of polycythemia vera, and it is one of the symptoms which can lead to mortality in these patients. These thromboses are basically because of an increase in the platelet count and increase in the erythrocyte count. This leads to obstruction of the blood flow. It can happen on an arterial level. It can also happen on a venous level. So we might have arterial thrombosis or the venous thrombosis. If you have a patient who has different types of thrombosis in certain unusual places, for example, in hepatic vein, classically called a Budd-Chiari syndrome, or in mesenteric veins leading to mesenteric ischemias, you might suspect that this patient might have polycythemia vera. So it is very important to evaluate that patient on these lines. Thrombosis is one of the major things that can lead to the stroke and other abnormalities in these patients, and it is the thing which we target the most when we look for the treatment modalities. Similarly, the intra-abdominal venous thrombosis can be present in the hepatic veins. It can be present in the mesenteric veins or the pelvic veins. Depending on the location of the thrombosis, the patient will be experiencing the symptoms. Hepatic vein thrombosis leads to Budd-Chiari syndrome. It can also lead to hepatomegaly. It can also lead to ascites or the portal hypertension. The patient might have an extended abdomen because of these symptoms if it is not cured in time or relieved in time. Then the small blood vessels, for example, the blood vessels that supply the digits, they might have an ischemic episode called digital ischemia. And this also leads to another important condition, which we are going to talk about in a minute. There is easy bruising because when the platelet count generally is increased and the platelets are normally functioning, but the abrupt increase in the platelet count leads to abnormalities in the platelets itself and the other factors which basically make up a clot. For example, the von Willebrand factors, they might get affected because of an imbalance in the platelet population in the bloodstream. This leads to easy bruising or an easy bleeding tendency. The patient might have epistasis. There might be bleeding from other orifices. Because of an increase in the histamine, the H1 receptors get stimulated. That leads to an acid peptic disease. The patient will have indigestion and all the symptoms of acid peptic disease. And if it prolongs and goes on for long, the patient might have a gastrointestinal hemorrhage episode or a hemorrhagic peptic ulcer. This hemorrhagic peptic ulcer can also lead to peritonitis in these patients, and this can be a life-threatening condition. So it is very important to look at the gastrointestinal symptoms in patients presenting with polycythemia vera. Erythemas and easy bruising, which is because of the platelet abnormalities. There will be burning pain in extremities and long-standing disease. This is because the nerves in the peripheral part of our digits they are not getting enough blood because of a viscous blood stream. It is basically, you can see that you can say that it is a similar presentation in diabetics, in which there is an occlusion of the blood supply of the nerves, in the digital nerves. They might have a gloves and stalking appearance. So this is the same pathophysiology in polycythemia vera. The difference being that this is the increased viscosity of the blood that is causing all of these symptoms. An important clinical condition is erythromelalgia. This develops in the patient, as we talked about in the previous slides. It basically encompasses the painful digits or the painful digital spasms. Erythro means the white red blood cells, and melalgia basically means a painful disorder. So because of an increase in the RBC count, the blood has problem getting to the extremities, and this leads to painful digits, the swelling, inflammation in the digits in the hands and the feet. So the erythromelalgia is a classical sign and symptom of polycythemia vera, and this also denotes the extent of or the intensity of this disorder, that because of an increase in the viscosity, the blood is having trouble reaching the extremities. Similarly, because of a rapid cell turnover and an increase in the population of the cells, the cell turnover leads to an increase in the protein production, and the protein breakdown leads to an increase in the uric acid levels. So we also have hyperuricemia in these patients. And this is also an important abnormality, because hyperuricemia on its own can lead to a lot of problems, for example, gout or the development of uric acid stones in these patients. And we have to manage hyperuricemia with the help of certain drugs like allopurinol to prevent these abnormalities. And overall, there is a hypermetabolic state in the body because of an increase in the cell production and then an increase in the cell turnover. The body is generally in a hypermetabolic state. These were all the important clinical features relevant to polycythemia vera. The patient might have only one sign and symptom at one presentation, or a combination of syndromes. So we have to look at the patient in a larger picture and evaluate the signs and symptoms. But the symptoms will be all relevant to the hyperviscosity because of an increase in the RBC mass. So that is the main basic underlying mechanism which you have to keep in mind while understanding the clinical symptoms. Now let's talk about how are we going to diagnose a patient with polycythemia vera. What are the different lab modalities that we have? The number one thing to look for in the patient is that there will be an increase in the RBC count, or RBC count can also signify an increase in the hematocrit or the hemoglobin levels. As you saw in the patient Smith in the case study, his RBC count was elevated, the hematocrit was around 66%, and the hemoglobin count was also greater than 20 grams per deciliter. Along with that, MCV might be a bit variable. Most of the patients, they have normocytic cells, but in certain types of population, there is an increase in the red cell distribution width, or the RDW. That means that the cell population might also be microcytic and also be normocytic. The microcytic population can be because of an iron deficiency anemia, and this might be in certain patients who have a gastrointestinal hemorrhage or certain types of bleeding disorders, or who are not adequately replenishing the iron stores in their body, because the iron stores are being used up continuously in the overproduction of the cells. So the red cell count is the basic thing which basically raises a suspicion of an underlying polycythemia. Based on these, how we are going to diagnose a polycythemia vera, and how we are going to differentiate polycythemia from the other types of polycythemias. This is a very important flow chart, and I want you to pay attention here so that you have a thorough understanding of what are the important relevant points that differentiate polycythemia vera from the other type of polycythemias. To start off, we have a patient with an increase in the hematocrit or the hemoglobin concentration. The next step is to measure the RBC mass. If the RBC mass is normal, then you can basically rule out the other types of polycythemias, and you can basically with confidence say that the patient has relative erythrocytosis. What does relative erythrocytosis means? That the relative erythrocytosis means that the RBC count is normal, but the plasma volume is generally decreased. This might be because of certain types of diuretics used or certain types of dehydration syndromes. We are going to talk about the various abnormalities in the coming differential diagnosis workup, which we are going to do in the coming slides. But relative erythrocytosis generally means that the RBC mass is constant, the plasma volume it is generally low. It is because of dehydration or any type of fluid loss that has led to this relative erythrocytosis. And you don't have to do anything, just replenish the plasma volume and the hematocrit will take care of itself. It is generally an accidental finding when you are evaluating the patient for certain other disorders. This generally happens in certain old age population or in some people who are living under very hot conditions, someone who has just run a marathon. You might find an increased hematocrit in those patients. Now, if we measure an RBC mass, the RBC mass generally signifies an RBC count, and we found the RBC mass to be elevated. What do we do next? The next step is to basically look for that whether this an increase in the RBC mass is in response to an hypoxic stimulus or it is irrespective of a hypoxic stimulus. What are the clinical markers that help us in identifying these things? It is the serum erythropoietin level. As we all know that the RBC production basically takes place in response to an erythropoietin production from the kidneys. The kidneys sense a decrease in the blood cell count or a decrease in the oxygen saturation, and that they release the erythropoietin, which lead to an increase in the RBC mass. So if we measure the serum erythropoietin levels and we find out that the serum erythropoietin level is low, this means that the increased RBC mass has led to a feedback inhibition of the serum erythropoietin, and this you can essentially rule out the other diagnosis and arrive at a diagnosis of polycythemia vera. So the serum erythropoietin level is the differentiating point of polycythemia vera from the other types of polycythemia, which are generally reactive polycythemias in response to hypoxia. When you have a low serum erythropoietin count, you can confidently say that the patient has polycythemia vera if the patient's clinical picture also fits the scenario. And then to confirm your suspicion, that confirmatory test is the JAK2 mutation or the genetic analysis of the short arm of chromosome 9, at which the gene for the JAK2 resides. So the genetic test, the confirmatory test, screening test you can say is the serum erythropoietin level. If you measure the serum erythropoietin level and it is elevated, then this generally means that we have certain hypoxic condition underlying. The body is not receiving adequate oxygenation, and in response, the kidneys have increased the serum erythropoietin production. Now, to differentiate the various types of hypoxic stimuli, we measure the arterial oxygen saturation with the help of a pulse ox. If the arterial oxygen saturation is low, then there is certain abnormality. We have to look for a heart or a lung disease. For example, the patient might have heart failure or COPD, or they might have recently moved to a high altitude. There is something that is not, the oxygen is not able to get into the blood. This is because, and in response to this, that low oxygen level, which we have measured by an pulse ox, the oxygen saturation is low, and this has in response led to an elevation of the serum erythropoietin level, which has in turn led to an increase in the RBC count. If the arterial oxygen saturation is normal, this means that the oxygen is being normally supplied to the body. So we don't have any abnormality of pulmonary disorder or a cardiac disorder, like we don't have a COPD or asthma or certain condition like these. Then we have to evaluate the smoking history of the patient if we have an normal oxygen saturation. If the patient is a non-smoker, then you look for the measurement of hemoglobin oxygen affinity, the various variants of the hemoglobin which have an increased affinity. If the patient has a positive smoking history, then you look for the carboxyhemoglobin levels in the blood. The carboxyhemoglobin also leads to an increase in the affinity of the hemoglobin. And if this carboxyhemoglobin level is normal, then again we suspect that there is certain underlying oxygen affinity problem. But if the carboxyhemoglobin levels are elevated, then we can confidently diagnose these patients as having smokers' polycythemia. Because of long-standing smoking history, certain types of smokers, they develop an increase in the carboxyhemoglobin levels, and that leads to other symptoms of polycythemia like the digital spasms or erythromelalgias or the various types of hyperviscous syndromes. On the other spectrum, if we have a non-smoker or if we have a smoker with a normal carboxyhemoglobin levels, we measure the hemoglobin oxygen affinity. If it is increased, then we can diagnose that patient as having certain types of hemoglobinopathies like the carboxyhemoglobin or the hemoglobin levels, which have basically an increased oxygen affinity, and there we have a diagnosis. But if the hemoglobin affinity is also normal, Then we have to look for certain paraneoplastic syndromes, because that erythropoietin that has increased and caused all of these symptoms, it is coming from certain other tumor in the body. Then we look and evaluate various types of body cavities. The number one tumor that leads to the production of an increased erythropoietin because of a paraneoplastic syndrome is the renal cell carcinoma. So we do an IVP or a renal ultrasound or a CT scan of the pelvis or the head or the abdomen. In the CT scan of the head, we look for certain types of rare tumors in the medulla or the cerebellum that can also produce erythropoietin. So this flow chart gives you a very good stepwise manner in which how we are going to proceed in a patient with an increase in the hematocrit or hemoglobin. By ruling out the various abnormalities, you are definitely able to arrive at a diagnosis, and then you can confirm your suspicion with the help of various other diagnostic evaluations. Now, let's look at the differential diagnosis of polycythemia vera. You have a patient presenting with certain types of headaches or certain types of visual disturbances. There is splenomegaly, there is erythromelalgia, and there are other signs and symptoms. How you are going to diagnose this patient clinically that this patient has polycythemia vera as compared to other types of erythrocytosis? The major types of erythrocytosis which we have to distinguish polycythemia vera are for example, we start off by differentiating them from the relative erythrocytosis. Relative erythrocytosis, as I told you, is because of a plasma volume abnormality. There is something which is causing the plasma volume to go low. That can be hemoconcentration secondary to dehydration or a diuretics use, which has led to depletion of the plasma volume. Ethanol abuse generally leads to an increase in the RBC mass, similar to use of an androgens. Androgens, for example, which we basically these are the cell products which we test in athlete when we are testing for the doping. The androgens lead to an increase in the erythropoietin production, and that leads to a relative erythrocytosis as compared to a normal. So either because of plasma volume depletion or an abrupt increase in the RBC mass relative to a normal plasma volume because of an androgen or ethanol abuse, that leads to the development of relative erythrocytosis. So ruling out these various factors on the history and clinical exam can help us differentiate this relative erythrocytosis from polycythemia vera. Similarly, long-standing tobacco abuse can also lead to relative erythrocytosis, as we talked about in the smokers' polycythemia in the previous slide. Now, if we have a patient with erythrocytosis and we suspect absolute erythrocytosis, what does that mean? Absolute erythrocytosis can either be in a response to a hypoxic stimulus, for example, as we saw in the previous slide, carbon monoxide intoxication, any type of hypoxic stimuli in which there is abnormality of oxygen passing into the bloodstream and there is inadequate oxygenation, it can lead to absolute erythrocytosis. High oxygen affinity hemoglobin, for example, HPF or other abnormalities. High altitude is one of the factors. Any type of pulmonary disease, specifically the COPDs or various types of asthmas, the right to left cardiac or the vascular shunts, sleep apnea syndrome in someone who is overweight and they have problem in the sleep. Hepatopulmonary syndromes can also lead to an absolute erythrocytosis. Other types of renal abnormalities can also lead to these problems, specifically the renal artery stenosis or the various types of glomerulonephritis like the focal sclerosing or the membranous glomerulonephritis. These are also a cause of absolute erythrocytosis, and these have to be clinically distinguished from the polycythemia vera. Post-renal transplantation rarely can cause absolute erythrocytosis. Certain types of renal cysts and a very rare syndrome called Butter syndrome. So the list is exhaustive, but the important ones to realize here are any hypoxic stimuli, specifically the COPD or the cardiac problems, high altitude or carbon monoxide intoxication, or in certain types of renal abnormalities like glomerulonephritis, renal cyst, or the renal artery stenosis. These can lead to absolute erythrocytosis, and we have to distinguish them from polycythemia vera, because in polycythemia vera we'll have problems with the platelets as well, but in erythrocytosis the problem will be limited to only the erythrocytes. Moving on, to complete the list of erythrocytosis, if we don't find a hypoxic stimulus or the renal problem, then we have to look for certain tumors and look for a paraneoplastic etiology. The important tumors that can cause are the hypernephroma, which is basically a renal tumor, or a renal cell carcinoma. This is the most common cause of paraneoplastic production of erythropoietin. Then certain types of rare hepatomas or the liver cancers, certain cerebellar hemangioblastomas. These are the tumors which we look for when we do a CT scan of the brain. Certain uterine myomas, which are very rare. Adrenal tumors, tumors of the adrenal gland. Meningiomas, also the tumor, if it is restricted to the meningeal cells, can also lead to erythropoietin overproduction and the symptoms of absolute erythrocytosis. Pheochromocytoma rarely can cause erythrocytosis. Certain types of drugs, just to complete the list, are, for example, the androgens. As I told you in the doping test, we look for these recombinant erythropoietin. The athletes can also abuse these recombinant erythropoietin products to increase their RBC mass, which enhances the athlete's stamina level or the oxygen saturation. And if we don't find any other abnormality, then in specifically young age patient, familial abnormalities also have to be evaluated. Certain types of rare syndromes like the erythropoietin receptor mutation or a VHL mutation, which can lead to other VHL abnormalities, or certain types of 2,3-BPG mutations. So these abnormalities are relatively rare. The important one to keep in mind here in the context of absolute erythrocytosis are the renal cell carcinomas or the cerebellar hemangioblastomas. These are the ones that generally lead to an erythropoietin overproduction or a paraneoplastic syndrome. These were the major disorders: relative erythrocytosis and the different types of absolute erythrocytosis, from which we are going to distinguish polycythemia vera clinically. And we have to rule out all these abnormalities to arrive at a diagnosis of polycythemia vera. And erythropoietin levels help us in guiding these, to ruling out these various types of abnormalities. Moving onwards, after this, let's talk about a few complications. The complications also are because of an increase in the viscosity of the blood, just like the various types of signs and symptoms. So what can go wrong? Because of an increased blood viscosity and an increased turnover of the red cells, we'll have all the symptoms. So increased viscosity can lead to various types of thrombosis, and increased turnover of the red cells can lead to hyperuricemic episodes and lead to the renal stone formation. Then the red cell mass is elevated because of an increase in the red cell production. Leukocyte mass is also elevated. This can also lead to problem in the viscosity of the blood. Similarly, the platelets width and the platelet size is also elevated, which can lead to problem with thrombosis, and it can also cause bleeding problems because of abnormalities with the von Willebrand factor. So these are the major players that lead to all the complications of this disease. Uric acid is increased because of the rapid turnover of the cells. This leads to uric acid kidney stones formation. It can lead to various types of renal abnormalities. It can lead to hydronephrosis, and even in long-standing patients can also cause renal cell carcinoma. It can also lead to the formation of gout, hyperuricemic disease. Similarly, an increase in the cytokine production because of the various types of cells being produced. The glomerulocyte monocyte colony stimulating factor might be overproduced in these patients. And these are the cells that we target when we look for treating these patients. Pruritus is because of an increase in the basophils, which lead to histamine release and itching in these patients. Echogenic pruritus, as we talked about in the clinic in the signs and symptoms, is a classical presentation of this disease, and it should always raise the suspicion of polycythemia vera in these patients. Similarly, peptic ulcer, because of an increase in the histamine release, the H1 receptors, they get stimulated in the stomach mucosa, and that can lead to development of the peptic ulcer in these patients. These peptic ulcer have a tendency to bleed. That can lead to formation of peritoneal abnormalities or peritonitis, or they can also lead to a rupture of the mucosa or the viscus, which can also lead to peritonitis formation. Painful splenic infarctions, because of an increase in the spleen size, the vessels get obstructed. So this over a long period of time can lead to painful splenic infarctions. The spleen might eventually get infarcted because of an increase in the splenic size. And finally, when over a large number of years, when the disease has progressed, the myeloid cell lineage basically gives way. It does not have enough repertoire or enough reservoir to keep up with the cell production. And eventually we reach a state of myelofibrosis, in which the bone marrow is generally replaced by the fibrosis, and the extramedullary organs, they get extremely enlarged, like the splenomegaly and the hepatomegaly. So when myelofibrosis develops, it generally signifies very poor prognosis for these patients. Increased hematopoiesis, which is basically the cornerstone of this whole disease, increase in the blood cell count of various types. Moving on with the complications, hepatosplenomegaly, as I told you, because of the extramedullary hematopoiesis, because the bone marrow is not able to keep up with the cell production, and it also signifies a failing bone marrow over a period of years when it is not able to basically make up the cell requirement or the erythropoietin stimulation. Mechanical discomfort is because of the enlargement of the various organs. If liver is enlarged and spleen is enlarged, then there is basically a mechanical problem in the abdomen. The patient might have back pains because the stretching of the peritoneum. The patient might also have ascites development, or a hepatorenal syndrome might develop. Transfusion-dependent anemia might develop in someone who is basically bleeding because of a GI ulcer. And portal hypertension, because of an enlarged liver, the portal vein gets obstructed, and downstream it leads to an elevated portal pressure. It can also lead to the development of ascites in these patients, and various types of varices can also form, like esophageal varices or the rectal varices. And finally, over a long period of years, the patient will progressively develop cachexia, which means that tumor necrosis factor and the other types of interleukins will be greatly increased in this patient, and this overall leads to a deteriorating health in these patients. So these are the major types of abnormalities. Polycythemia vera rarely has a tendency to transform into certain types of leukemias. The important leukemias in which it can transform are the acute non-lymphocytic leukemia, but more commonly it transforms into an acute leukemia, which is a lymphocytic leukemia, or ALL or AML. But it is very rare for these disorders. The other types of chronic myeloproliferative disorders, which we are going to talk about in the coming slides, they have an increased tendency to basically transform into leukemia, like the CML and the other type of chronic myeloproliferative disorders. Erythema, just as we talked about on the slide, and finally erythromelalgia, which is basically signifies all the problems that the patient will have: painful spasm, painful digits, painful extremities, swelling, warmth, all the signs and symptoms of inflammation, the rubor, calor, dolor, they all will be present in these patients. Similarly, pain of the affected appendages, the fingers, the digits, and digital infarctions. If the blood supply is occluded over a long period of time, then their digits can get auto-infarcted, or the digits can basically amputate on their own if, for example, the blood supply is occluded for a long period of time, specifically the arterial blood supply. And this is very painful in these patients. It's just like having someone with sickle cell auto digits infarction, as we talked about when we were discussing the sickle cell anemia. Migraine can develop, specifically ocular problems, they can also develop. So these were the plethora of complications and the plethora of clinical signs and symptoms that patients with polycythemia vera present. It has a lot of varied presentation, but the basic pathophysiology, if you have a good understanding of what is the underlying mechanism of all these abnormalities, then you will be able to arrive at the complications and the various types of clinical abnormalities on their own, just by having a thorough understanding of the disease. Now let's look at what are the various treatment options that we have for the patients with polycythemia vera. The major treatment modality which is present for all these patients is the periodic phlebotomies, or the removal of the blood over a short period of time. That is the major mainstay of treatment, and it increases the prognosis. The patient can live longer with these periodic phlebotomies. Along with that, we can use certain types of drugs which basically target certain complications or the certain clinical symptoms. There is not one curative treatment because it is a genetic problem, and we don't have a cure for it yet. But the various types of drugs which we use cater to the various types of complications that the patient is experiencing. For example, if someone is experiencing a lot of pain or painful digital spasm, then we might use certain types of salicylates in these patients for the relief of the pain. If someone is having thrombotic episodes, then certain types of anticoagulants can be used to break down these thrombosis to prevent the development of certain types of strokes or the hepatic vein thrombosis. Allopurinol is a drug which is basically used in someone who has hyperuricemia, or the uric acid count is greater than 10 This is because of a rapid cell turnover, and that increased uric acid count has a propensity to develop the gout in this patient, or to develop renal stones. So we give allopurinol to basically bring down the uric acid level in these patients. Similarly, certain types of mediators like the interferon alpha or the ultraviolet therapy, this is used for patients with erythromelalgias, or someone with hepatosplenomegaly, in which we have splenic infarctions. That UV light therapy is effective. Hydroxyurea is another type of antimetabolite drug, which also has its toxicities, and we have also can also replace it with PEG interferon or certain other types of drugs like anagrelide, which has a similar mechanism of action. These drugs all target the various types of complications. For example, development of infarctions, thrombosis, or an increase in the splenic size, and the various types of abnormalities in these patients. There is no curative treatment, so the treatment is basically symptomatic. Whatever the symptom is most troublesome for the patient, it is the one which we target. And all of these basically are supplementing our major treatment, which is the phlebotomy. Recently, certain types of autoimmunity drugs have been developed, like the ruxolitinib here. It is basically an anti-JAK2 drug, which with the help of this drug we have tried to target the JAK2 receptors, which are the basic underlying problem in these patients, and it has led to various types of mixed results, and the data on it is not significantly widely available as for yet. But this drug has been used, and in certain patients it has provided relief of the symptoms, in others it has not. So this is under trial, and with increasing advancement we'll have more information about this drug. But the major mainstay of treatment, as I told you, are the periodic phlebotomies. What we do is we basically cut and remove the blood over the patient, a certain amount of blood. This leads to a decrease in the viscosity of the blood. It leads to better fluidity, increase in the movement, and improvement in the overall symptoms of the patient. And then after a certain period of time, depending on the patient's response and the patient's condition, we can repeat this phlebotomy procedure again. And this also prevents the patient from the development of iron overload and other types of abnormalities. So this is at the time the major mainstay of treatment, and the other types of drugs are basically there to supplement it. And finally, if we have a large spleen which is causing splenic infarction and which is causing trouble to the patient, then we might have to do splenectomy in these patients to get rid of these complications. And with splenectomy, as you all know, we have to take certain precautions. We have to vaccinate the patient against certain types of microorganisms, and then we have to give those patients autoimmune drugs for the rest of their life. So these are the major treatment modalities that we have as for now to combat polycythemia vera. So with this, we complete our discussion of polycythemia vera. In the coming lecture, we are going to talk about the other types of chronic myeloproliferative disorders, like the essential thrombocytosis or the myelofibrosis. Till then, I hope you have learned something new in this lecture, and then I'm going to see you in the next lecture. Thank you.